Moving to Live is a podcast about movement and exercise. We bring you interviews with professionals in the movement and exercise field. The goal is to provide information for other professionals and also amateur movement aficionados, people who understand that movement is part of what makes life complete. Some of the people we interview you will have heard of. They're well known in and outside of the movement and exercise profession. Others you may not have heard of, but they have a great deal of knowledge to share. Many people doing the best work spend their time working with people, not working on their social media presence. We're going to give you a chance to learn from some of these talented and knowledgeable individuals, and we're going to learn along with you. Moving to Live podcasts are going to be short. Each interview will be long enough to impart usable information, but short enough to be able to be consumed in a single bout, during your workout, commute, or even during dinner prep. We all like long-form interviews, but time is valuable. Moving to Live wants to give you the option to learn and be entertained without needing to commit 60 minutes at a time for an interview. Give Moving to Live a listen. Check out our sister podcast, FitLab PGH, which highlights people, businesses, events, and activities in the Pittsburgh, Pennsylvania area that make movement a priority. Moving to Live would love to hear from you. Want to connect with us or have an idea for somebody you think we ought to interview? Drop us an email, mov2liv@gmail.com, or connect with us on Instagram and Twitter, both _mov2liv. We're excited to bring you these interviews, and we think you'll enjoy each and every one that we bring you. Welcome back to another Moving to Live podcast. We try to break down the knowledge silos, interview people across the movement field, both for movement professionals and amateur aficionados. We do have the ethos that movement is a lifestyle, not just an activity. Sometimes the guests that I want to have on take a while, or sometimes I'm out for a walk or a run with my dogs and realize, this is somebody I know. Why haven't I asked them before? This is one of those people. I don't know how many years I've known him, probably through email. Actually met him a little bit over a year ago in person. Big fan of my Labradors. And I think he's got an interesting background because his claim to fame, or one of his claims to fame, for those of you who are academic nerds or meatheads, is the fact that he's one of the few people with a master's degree and not a doctorate who is a fellow of the American College of Sports Medicine. I think there's only 2 or 3. We'll probably talk about that. But he's a runner, a native New Yorker, and we are here with Paul Sorace. Paul, thanks for taking time to talk to Moving to Live.
Thank you, Ben. Pleasure to be here.
My favorite first question that I always ask on Moving to Live, it's kind of like the elevator spiel. You're there, you're standing in an elevator, the elevator happens to get trapped, and somebody says, "So what do you do?" What's your little spiel, or what's your comment when people ask you what you do? What's your response?
Well, I always like to say that I'm a clinical exercise physiologist, but I've become used to the fact that now I just say I have a master's in gym. And then all of a sudden they get it. So they're like, "Oh, so you're like a physical therapist?" I'm like, "Yes, but no." But no, I'm a clinical exercise physiologist. And when I break it down, when I'm actually out on a date, non-COVID, and she wants to know about what I do for a living and what my profession is, I say that I am similar to a physical therapist in a sense. It's just that the populations that we treat are different. You go to a physical therapist because you tore your rotator cuff or you had ACL surgery. You come to me because you have a systemic disease. So you have hypertension, open heart surgery, you have type 2 diabetes, obesity, asthma, and I treat the body systems in conjunction with medications that you're on in order to get you to be, feeling better and doing well and increasing your wellness and your fitness. So, again, I have a bachelor's degree in biology. My master's is in exercise physiology. Got certified with ACSM, NSCA. Then they wrote me into all their committees, and I did all that jazz for a number of years, which I still do. And so I guess I'm rambling, and what I really should just say is I'm an exercise guy.
And I know I want to come back in a few minutes after we cover a little background and talk a little bit about why, if somebody has these systemic diseases, seeking out a clinical exercise physiologist might be better than just a, no insult intended, but a plain old personal trainer or somebody who works in a fitness facility, because I think educating is important. But you mentioned undergraduate degree in biology. So I guess the first question that one has to ask is, growing up, were you an active kid? I know you're a runner. You like to stay active. Were you an active kid, or was that something you found later in life?
I was always active as a kid. I definitely was, but I was always the last kid picked for the pickup game of tackle football or stickball or basketball. My eye-hand coordination was terrible, but I loved the training aspect of it. And so when I got into high school, I started lifting weights. I just went into the gym after school and I lifted weights, and I got pretty muscular, pretty strong. And then, like I said, I was pursuing my undergraduate degree in biology, and I was in my early 20s. I was still trying to find my way in life and not sure what I wanted to do. But that's when I got my first job as a personal trainer at a fitness facility in my hometown. And I fell in love with it right away. And I was just like, can I do this as a career? But I was like, I don't know if I could see myself doing 35 to 40 one-on-one hour sessions as a personal trainer, because the burnout rate is extremely high, as it's well documented. So then I started looking into what else can I do? And that's when I started considering physical therapy, maybe go for an ATC. And then ultimately I gravitated towards exercise physiology. And that's pretty much the rundown of my career up to this point.
I think it's a great time to mention or provide clarification, because I know some of the people who listen to this podcast are either parents of college students or college students. And I think as well as me, the names of the various degrees for our field, exercise physiology, depending on the school you're at, sports medicine, kinesiology, some schools that may be physical education with a concentration, et cetera, et cetera. And you mentioned it at the top of the podcast, you are a clinical exercise physiologist. So I think you gave a great explanation of how you transitioned from the biology degree to going and getting a master's. But how does what is a clinical exercise physiologist versus somebody who's just an exercise physiologist, or somebody who says, hey, I've got a master's in exercise physiology? Because I know you've done quite a bit of writing, which we'll touch on. But what differentiates it where you can say and actually be correct and not just blowing smoke? I'm a clinical exercise physiologist.
I think the biggest differentiation is that the clinical EP, he or she has the knowledge, skills, and abilities to work with the disease population. They're on a number of medications. They have these comorbidities. And so they need to exercise, but you need to understand what medications they're on, what their disabilities, their chronic diseases are, and how that works, as opposed to an exercise physiologist, or I guess in the industry, it's called an applied exercise physiologist versus a clinical exercise physiologist. They're just someone who understands, obviously, the physiology that goes on with exercise, but they don't have a deeper understanding that the clinical EP does in terms of dealing with someone, say, has the metabolic syndrome, or has Parkinson's disease or multiple sclerosis. And so I think the clinical exercise physiologist is the person who is probably better prepared to work with someone who has, again, some type of chronic disease or disabilities, who need attention with their exercise programming related to their disease. And like I said, medications that they may be taking and how that may affect the exercise response.
And is that for somebody who's listening to this, maybe thinking, because of COVID, I'm going to do a career change, or, they're still in college. Is that something, the clinical exercise physiologist, is that a specialty that you can get when you get your master's degree? I know you also have some certifications. I know ACSM has a very credible one in that. I know that NSCA has a special populations certification that looks at exercise for people with chronic diseases. But, how did you fall into, this is clinical? How did you get the expertise?
Well, actually, my master's degree, my graduate degree, is in applied exercise physiology. But then I went on to I took the pilot exam in 2000 in Indianapolis, the registered clinical exercise physiologist with ACSM, which is now certified exercise physiologist. We've changed the terminology. But whatever, the exam is the same. It was crazy. I took the first exam and the pilot exam, and I went into this room in the Marriott in downtown Indianapolis, and there's like 20 people in the room. And I was expecting to walk in there and like hundreds are going to be out because this is like the first exam that's specific for clinical EPs. And it's like 20 people in the room. And Tom LaFontaine is sitting next to me and he's my mentor. He's the founder of the special populations column for SCJ. And he's sitting there and he's looking at me and I'm looking at him. We're doing like one of these, like where is everybody? But I would say that that's where my training came from, because then I got my first job at Hackensack Medical Center in the Asthma and Allergy Center, which is kind of unique. People are like, oh, you're an exercise physiologist working in an asthma center? And like, yeah, there's people who have exercise-induced asthma and they have exercise-induced anaphylaxis, which is pretty scary. And so I did testing and training for those people. And then I went to phase 2 cardiac rehab, where I was for the last 12 years until I left 2 years ago. So I would say the basis of my training as a clinical professional really does come from ACSM. I love NSCA. I'm totally committed to the organization, but the specific skill sets that I have for working with disease populations, I believe comes from my ACSM training. The certification, and obviously continuing education with the journals and so forth, and attending conferences and so forth.
And for somebody who's listening to this, I mean, I know when I was, say, 22, 23, I went the athletic training route, but the idea of dealing with people with chronic disease is like, no, I want to deal with athletes. And now that I'm a little bit older, I do a little personal training on the side, having had the opportunity to work with somebody who unfortunately passed on from cancer, working for a number of years with a lady with rheumatoid arthritis. These are some of the most rewarding people to work with, even more rewarding than training that runner to break 3 hours in the marathon, or training, somebody just to finish their first century bike ride. Because I can still remember with the lady with rheumatoid arthritis, she got stronger. We did some resistance training. She went on a trip to New Zealand with her husband. And I just suggested, just as a flyer, you might be able to walk a little bit more than you normally do with your husband if you took a pair of hiking poles. Little did I know when I get a text message from her in a field on a cliff overlooking the ocean that she decided that she was going to go out and hike 10K. And the fact that she could do this, she's like, I couldn't have done this without you. It's like, no, I gave you the tools to do it. You did the work. So I think one of the things that people miss when they listen to somebody like you or me, I'm a little bit older than you. It's like, well, yeah, he's a clinical exercise physiology. That's nice, but I want to work with athletes. But I think one of the things that people are missing when they think about clinical exercise physiology is the opportunity you have to literally change people's lives, because many of people with chronic diseases, 20 years ago, as you said, that was the infancy. 25 years ago, you had, cardiac rehab was around, but many of the other chronic diseases, like, well, you have this disease, you shouldn't exercise, don't exercise. And now they're like, yes, you should exercise, but you need to exercise responsibly.
Right. And it's funny that you mentioned that, Ben. There were so many people who would come into cardiac rehab, men and women alike, who had open heart surgery, although it's not open heart technically, but they call it open heart surgery. And they think their lives are over. It's it. That's it. They're done. They have nothing left to give. And then all of a sudden we start getting them on the treadmill, and we're on the recumbent bike, and they're on the new step. And especially with the men, we start moving the iron a little bit again. And you know what? It's okay to still lift weights. You can lift more than a gallon of milk in terms of weight. And all of a sudden they feel like, they are still alive and they still have a lot to live for. And so that's probably the most rewarding component of what I do, is when someone comes in and they had some type of event, they had an MI, they went into cardiac arrest, they needed CPR, which I had to do once on a Queen's 10K, but we could talk about that later. Very stressful experience. But just to be able to help people to just get back to some type of normalcy in their life. And like you said, you and Lisa always say movement. That's probably the most rewarding part of what I do.
And I'm curious with this along the same realm, because I know you are active with the National Strength and Conditioning Association and ACSM. It seems every other health fitness journal I pick up, you're author or co-author.
Appreciate that, Ben.
Many people, I mean, one of the things that I've always told my students and said to people, it's like, you pay for these certifications and you can read on social media, I can't believe I'm paying this money, or I gave up this certification because of the organization. They're not doing anything for me. And I know that you have the certifications, it's fairly easy, but yet you continue to give back both to ACSM and the NSCA through writing and through service. Talk about that. Why, when so many people, and I mean, obviously many of the people we associate with do as much or more than either you have or I do, or ever will do, but there's also a huge number of people, who just, they pay their whatever $100 a year, or they maintain their CEUs and do anything else. Why the contribution and the, emailing me and say, hey, if you've got an article that you need reviewed, I'm your man, I can do this. Why do that rather than just sit back and say, okay, I paid my $120 or $135 to the NSCA and whatever it is to ACSM, and I've got my certification?
That's a very interesting question, Ben. I guess because I'm not complacent. I still feel that, at the ripe old age of 48, the hair is thinning. I still have a role in the industry, and maybe that's part ego. And if that's the case, I accept that. But if there's something that I could contribute to people who are following in my footsteps, so to speak, then that's something that, encourages me, motivates me, because I was there once. I remember when I started subscribing to NSCA's Strength and Conditioning Journal years and years ago. Cheese and crackers. I remember I was reading it. I was in the airport in Nashville, Tennessee, and I was coming back from ACSM's national convention. This has got to be going back 15 years easily. And I'm looking at the articles and this, that, and the other thing, and I'm recognizing names and so forth. And I'm looking at the masthead, and I'm like, I said to myself, like, wouldn't it be the greatest thing in the world, the coolest thing for me, as silly as it sounds, to have my name listed on the masthead of NSCA's SCJ? And now it's there, and it's in every issue. Now I'm like, yeah, there it is, whatever. But I guess my motivation is to continue education, because we're constantly learning something new, and we're learning something new about COVID practically daily, and everything else, from resistance training to aerobic training to working with special disease populations. I just feel like there's still a place for me to contribute to the profession, which I'm very, very passionate about. I'm not getting rich by it, but it is keep my head above water.
And I think you hit on a couple of things there that I think are very important to emphasize. And I think people who maintain active memberships and get their names on the mastheads or get their names on committee listings, very often for little or no pay, except for maybe a meal or so here or there. But at the end of the day,
I picked up a tab in DC for me, you, and Lisa.
but at the end of the day, if you're in the movement field, part of what, or a significant part of what you do, is you teach. I mean, it may not be going into a classroom, but you writing an article and talking about, these are some things to look at for COVID, for return to exercise in COVID, or, if you're working with a client one-on-one, that's teaching, because, you may say, well, I'm just spotting them, or I'm just taking them through a cardiac rehab workout.
Right.
But those same things, if you're working with somebody and they come back to you and say, oh, I was doing this in the yard and I was thinking of you. You were in the back of my head, and you were saying, I heard Paul say, when you lift, make sure you do this. It's like, and I did that. And that's actually something that I think many people say, well, I've got to do whatever it is I have to do in the movement field. They don't realize that at the end of the day, the most important thing they can do and pass on is teach.
Agreed.
Along those lines, to kind of build that out, is one of the things that I think is so unique about both the American College of Sports Medicine and, to a lesser extent, the NSCA, because it's a newer and it's smaller, is the wide variety of professionals who join those organizations. I mean, I know one of the interesting things you mentioned that you recognize names on the masthead when you were looking at the National Strength and Conditioning Association Strength and Conditioning Journal. Probably very similarly with ACSM, you recognize these names of people, And there are people literally breaking down knowledge silos, because I know in ACSM, you just co-authored an article with a physician who's very well known in the running world.
Yes, good man.
What was the impetus, or why was it? Because, ACSM has a reputation for being clinical. If you're interested in the clinical aspects of exercise, you do ACSM. If you're interested more in the performance aspects, you do the NSCA. And, there are a large number of people who cross over, but there's also a large number of people who are members of both organizations who kind of look at the other organizations like, well, I see why that's important, but that's not me. Other than the ego trip, and I'm joking here and being sarcastic, the ego trip of working to be on the masthead of a journal at the NSCA, what was the impetus as a clinical exercise physiologist to say, hey, I'm going to jump over a little bit, maybe a little bit out of my comfort zone? Although as a runner, some of it might also have been, hey, what can I learn that might help me run a little bit faster time?
Well, Ben, it's interesting. The article, the column, medical report column that's in the current issue of FIT, ACSM FIT, as it's called, was me along with Dr. J, as he's called, long-time friend of mine, and then Tom Mahadi, who I worked with for a lot of years. And then it was Dr. Roberts, who was one of the reviewers. And he came back and he had a few minor comments, and he asked if his name could be put on as one of the co-authors. And we found that totally flattering. And so it was just really, it was really a good feeling. But with the NSCA, again, it goes back to, when I talk to so many of my interns and they talk about, NSCA, that's when you're working with athletes, and that's strength and conditioning, and that's powerlifting, and that's Olympic lifting. I'm like, no, you also can be an NSCA certified personal trainer, which focuses on working with clients who have medically controlled chronic diseases and disabilities. And I just feel like that's, and Jeff Chandler told me this not too long ago. He said it probably will never be the biggest part of the NSCA organization, but it will always be an important part, and we need to have that. We need to have education, as you were mentioning, whether it comes from publications, presentations on, okay, so someone has this type of condition here, and here are the do's and the don'ts and the recommendations based on what the national guidelines tell us. So I feel good about my role in the sense that it's unique, or the minority with NSCA, but I feel I still have a role there, and it just that's my stick.
And I think one of the things that I've found, and I can speak because I've been much more active in the NSCA, is there's always the opportunity, if you're interested in something, somebody's not going to say, oh, we're going to do that. Especially, you mentioned Jeff Chandler, the longtime editor of the Strength and Conditioning Journal. Jeff is probably much better known for saying, well, why don't you do that? Or why don't you try writing? I know, for example, in the early 2000s, there was an endurance activities column because I was big into triathlons. And I said, there needs to be an endurance column. And rather than doing it, Jeff said, well, why don't you recruit some authors and take it through the peer review process, and we'll do that. And I think there's the opportunity, and I think by you telling your interns that you've had that, no, it's not just go in the gym, get stronger. There's the opportunity to create your own path and basically expand your knowledge base outside of, okay, I'm a clinical exercise physiologist, or I'm a meathead, and I don't mean that in a negative way. I remember talking to a longtime strength coach who transitioned out of the strength coach, still in the field. I think that's a theme. Many of us go through multiple careers in the field, or multiple specialties. As you mentioned, you'd left the clinical physiology aspect. And one of the things that I was amazed is he goes, I'm too big. I'm never going to run a marathon. He says, it doesn't make sense for my body. But he did a 100-mile mountain bike race because he said, if I'm going to be working with clients who want to run a marathon or want to do a triathlon or want to do something like that, I need to know what they feel like. He said, I'm never going to be as fast as them, but I need to know what it's like to actually train. And, if I'm going to write a program, I need to understand what it is. And you were mentioning your coach who took you through 3-hour or sub 3-hour marathon who I think you said maybe had never broken 4.5 or 5 hours. And I think that's an important thing that very often is missing in the fitness field. It's like, oh, well, you don't look like a runner, so you can't be a good coach, or you don't have a six pack on your abs. So, I don't want to come to you to lose weight. And you really miss out, as we were chatting before we started recording, one of the reasons for Moving2Live is to give education, to realize that just because you have 50,000 followers and look good with your shirt off doesn't necessarily mean you're the best person for training somebody, because A, you may not have the basic knowledge, and B, to come into this, you may have an ego so big, or you may not, that you're not going to recognize somebody else who knows more than you. And I'm going to kind of give you the opportunity to toot your own horn a little bit, because I know I follow you on social media and a couple of your running friends. And one of them mentioned a friend who had a weird symptom during a run that turned out to be a specific type of stroke that was very unusual. And, I'm just kind of reading through it. And then you popped in and what, you were popping out the statistics and things like that. And I think the take home message from that is, you always need to have your circle or cadre of people who are outside your area of expertise, because then you're going to look really smart to your clients, because you're going to be able to get the answer for them, and you're going to learn yourself. So I think when you hit on the fact that it's like, I was a clinical guy, but I saw the opportunity with the NSCA. I think the most valuable thing with education and with being in this field is to expand your network, not necessarily the beer drinking buddies or ladies that you go out with at the conferences, but the people that if you don't know, you can call them up and say, hey, Ben, I don't know shit about this. You tell me what you know. And I'm not going to go, oh man, Paul, how do you not know that? You're an idiot. How did you get into that? Or was that something that you just naturally, it was easy for you to call people and say, hey, can you tell me about this? Or can you give me the opportunity to help out on this?
I've always believed that the best thing that you could do, certainly with your career, is surround yourself with people who are more knowledgeable than you are. And I've always tried to do that. And I think I've done that with some success, a modicum of success. But I think it's just a matter of talking with people and networking with people and establishing relationships with people who work in your profession and maybe have specialties that you don't have. Listen, nobody's an expert on everything. No one's an expert jack of all trades. We all have our specialties on what we're confident in and what we have a lot of knowledge and experience in. But then there's other areas. I'm not an ATC like you are, Ben. So when it comes to something like physical therapy or rehabbing from some type of an ACL injury or an MCL injury or whatever, I'm going to trust you more than I'm going to trust myself. And it's just a matter of it's a matter of not having an ego and just, networking with people and surrounding yourself with people who are as knowledgeable as you are, or in many cases, in my case, more knowledgeable than I am. And then it just elevates you to the next level. And so it just comes down to a matter of that, in my opinion.
I think that's well put. I know that I came across a personal trainer's website fairly recently. I won't say the city they're in, et cetera. I won't say the name, but apparently this individual was an expert in dealing with postpartum, dealing with powerlifting, dealing with high school athletes, dealing with elderly, dealing with people who have cancer, dealing with endurance athletes. And I'm thinking, wow, this is really somebody who really is an expert in so many fields. And I'm being somewhat facetious with that, because I think a good personal trainer can work with all of those things. But at the end of the day, those people I think who are really good are those who can say, I can work with this realm of people. These are the people that I'm best working with. I've brought this up before in other podcasts. I've had a number of retinal surgeries because of a congenital problem with my eye. And I remember having to have a procedure done in the retinal specialist's office, and him saying, let me see if my colleague's here, because I can do this, but my colleague is way better at this. And I remember just thinking, it's like, wow, I'm not at all nervous, even though they were sticking a needle in my eye, because here's a guy who says, look, I can do this, but let's see if somebody else is. So one of the things that people are going to say, if somebody asks you, Paul, what is the type of person that if they say, what is the type of person that you have the best results with, that you feel most comfortable dealing with? Is it somebody who has a chronic disease? Is it somebody who's an up and coming runner? Is it somebody who just wants to improve quality of life?
That's a good question, Ben. I would have to say dealing with someone who has some type of comorbidity or comorbidities going on. They come in, they have hypertension, they have metabolic syndrome, they're obese, they have osteoarthritis, they have rheumatoid arthritis, they have Parkinson's disease, because these are people that I have dealt with through the years and have, again, used my knowledge, skills, and abilities to design their program so that it's safe and effective for them. And it's really not that much different from as I say, and I always quote, apparently healthy individual. But there are some considerations that you need to recognize and adapt their program to. But I am comfortable working with someone who wants to build muscle, as you said, the meathead. If they want to come to me, if they think I can do it, I know how to recognize, the acute variables to maximize muscle hypertrophy. But I would say the disease population is probably where is my forte.
And I know you mentioned that you sometimes work with interns. If you're talking to a group of interns and they're getting their undergraduate degrees in exercise physiology, maybe they're not getting a master's immediately. They may wait a year. We all know some people don't get master's degrees, which is fine. Some people are blooming idiots and go on and get a doctorate degree like me for some forsaken reason. And I say that my reason was I wanted to play for another 4 years. Totally joking with that. But, if you had to say that, looking at the interns that you've had and knowing what you know about education that people get in undergrad, somebody says, Paul, I'm graduating, and it's a strong program. What are the one or two areas that you might say, if these two areas of really focusing on maybe taking a weekend seminar or going to a conference that specializes in these areas, what are the areas that you frequently see with interns that they could use a little bit more knowledge that they're not getting?
Yeah, that's a tough one, Ben. I'm going to be completely honest with you. The majority of the interns I've worked with go on to become physical therapists, physician assistants, or they even go to medical school. And they say because there's not many opportunities for a clinical exercise physiologist, they don't make great money. When I worked at Hackensack University Medical Center, this is the biggest hospital in the state of New Jersey. It employed 10,000 employees, full and part-time. That's how many exercise physiologists they employed.
Paul's holding up two fingers.
Yeah, yes, thank you. Thank you. 2 fingers, not the middle finger. And so that's what turns a lot of the interns off and the undergrads off. They're like, there's no money to be made. I see what the pay scale is for an EP or a clinical exercise physiologist versus a physical therapist or a physician assistant or an advanced nurse practitioner. And so I'm going where the money is, and there's more growth and there's more opportunity there. So it's a difficult question for me to answer, Ben. I'm actually I think as far as I know, I'm one of the few still hanging around, without teaching at a university, who's still a practicing clinical exercise physiologist. I don't know what the future holds as far as opportunities for exercise physiologists. I mean, sometimes some people can say, an exercise physiologist is a glorified personal trainer. Not really. I've seen some of the certification exams out there. One of them, who I won't mention, as you mentioned before, I looked at their sample 10-question multiple choice, and one of them was true or false. Do you work the biceps muscle during a bicep curl? True or false? I mean, really. So to become a personal trainer and be certified, it's not that difficult to be, but are you a good one, or are you a knowledgeable one, or you're not? So I don't know if I have an answer for you, Ben, because, I'm actually a little bit discouraged with the future of the profession. I mean, there's the, the CEPA is trying to advance and get licensure for clinical exercise physiologists, which is only legal right now or legit in Louisiana, but it's not even an exam. You fill out an application and you become a licensed clinical exercise physiologist. Where's the exam? There is no exam. They're trying to create one in Massachusetts. It's been going on and on for years, and there doesn't seem to be any progress. So I don't know if I have an answer for you, Ben. I mean, it's just it's a laudable profession, but the opportunities to be a clinical EP, they are limited. They really are, and there's no way for me to sugarcoat it.
And I think that's well put. I think it's something, if you think about chronic diseases. I mean, obviously, some of them, you can't pick your genetics. But we know that many of the chronic diseases are related to a lack of exercise or a lack of correct exercise. And I think just across the movement field, whatever you want to call it, somewhere, somehow, the boat has been missed on putting a priority on regular movement. I think the statistic I saw is there's something like 27% of Americans do no regular movement at all. And you're probably better up on the statistic for this than me, but I suspect, chronic obesity, just as one morbidity, is probably at least 50% in the United States.
I don't know if it's quite that high. Overweight is definitely in the realm of 2/3. I think the last I saw, don't quote me on this, I could look it up, I think of roughly 35 to 40% are extremely obese. We no longer use morbid obesity. Now it's extreme obesity. But about 2/3 are overweight. And there's no question that lifestyle factors into that. It's going to McDonald's too often, not going out for the walk with Maggie and Puddin', and just staying home and putting your feet up and putting the TV on and listening to the news and this, that, and the other thing. And there's no doubt that lifestyle factors in. Of course it does. And it's something that we just need to continue to champion to the American public and to the world public, for that matter.
We're talking with Paul Sorace. Got one final question for you, Paul, since I know you just recently authored an article on this. Hypothetically speaking, we get a vaccine for COVID, things return to, and I'm using air quotes, normal, where you see people one-on-one and you're actually able to work with them other than Zoom, or you see them comfortably. What are the one or two things that somebody should be concerned about who's in this field, who has an athlete or a client who comes to them and says, I was diagnosed with COVID, the doctor cleared me, I'm good to go. What are the kind of like the red flags that if you're working with one of these people saying, okay, I want to make sure of this, not only to cover my butt, but also to make sure that we don't have any long-term problems? Well,
really the only thing we can go on right now is what we know. Wear a mask, wash hands frequently, social distance, and just go with those three. Those are really the only three, and that's discussed in the manuscript that was published in ACSM's Fit journal. That's really all we have right now until a vaccine has been, validated and is legit. It's a matter of the masking works, social distancing works, washing hands works. Don't touch your nose, don't touch your eyes. It's not a respiratory disease because the last time I checked, we don't breathe through our eyes, so it can get in through the eyes, and just practice those safe hygiene, acts. And that's really what I would focus on and what I am focusing on with my clients that I'm working with right now.
And it's kind of like people don't want to necessarily hear that because it's not cool and sexy and neat. It's just kind of not really common sense, but it's just kind of, do these things. And it's, but there's got to be something more. It's like, not until we have more research that shows that.
That's correct. And that's why we even mentioned in our column in ACSM's journal that this is what we know right now. And there's going to be ongoing research and data. And by the time this article is published, which it was, it might be slightly outdated based on what we've learned since then. But when we wrote it at the time, this is what we know right now. And from what I'm reading and from what I'm hearing, it still has merit. So I'm kind of happy about it.
We've been talking to Paul Sorace. He is a clinical exercise physiologist. I think he's given us some good information across the board about the importance of movement as a lifestyle and just his path as a clinical exercise physiologist. Paul, I want to thank you for taking time to talk to Moving2Live.
It was an absolute pleasure.
Thanks for listening to the latest episode of Moving to Live. Make sure you check out the show notes for contact information for our latest guest, as well as links about all the things we talked about. Intro and exit music is Traveling Light by Jason Shaw. You can subscribe to Moving to Live on Stitcher, Apple Podcasts, and Google Play, and be notified about new episode releases. Have any questions, comments, or suggestions? Drop us an email, mov2liv@gmail.com. Connect with us on Twitter or Instagram, both _MOV2LIV. Please tell your friends about Moving to Live. It's a go-to place for information for movement and exercise professionals and amateur aficionados who understand that movement is part of what makes your life complete. Until next week, keep on moving.